Welcome, everyone, and thank you for tuning in. My name is Rachel Bacon, Senior Program Manager for the Boston University Center of Excellence in Maternal and Child Health, and I will begin the webinar with some very brief housekeeping items. For audio and listening in, please use your designated dial-in or use your computer audio. Please note, all attendees will be muted for the entirety of the webinar. Throughout the presentation, submit questions in real time using the questions option in your side webinar tool tray. This is in the window that pops up when you sign in for the live presentation. Now, without further ado, I'm handing over the reins to our moderator for our session, Lois McCloskey.
Good morning and afternoon to all who have joined us online and in person for Equity, Autonomy, and Substance Use Disorder, Lifecourse Considerations for Pregnant and Parenting People. As Rachel said, my name is Lois McCloskey and I direct the BU Center of Excellence for Maternal and Child Health Education, Science, and Practice. And I'm joined today by Dr. Henning Tamir, Director of the Harvard School of Public Health Center of Excellence, as well as our two program managers who have been the brilliant organizers behind our event, Rachel Bacon of BU and Bethany Kotler of Harvard. Together, we welcome all of you who have joined us in person here at BU and online. The number of you who have registered and are here in attendance, over 900 people, is a testament to the broad significance of our webinar topic. Among us are many members of the public health workforce and leadership in local and state health departments across this country, many on the front lines of substance use treatment and the care of pregnant and parenting people, including recovery coaches, doulas, physicians, nurses and nurse midwives and midwives, social workers, mental health counselors, advocates, and researchers alike. We chose today's topic for its cross-cutting relevance at this moment in time, as it lies at the intersection of reproductive justice, child welfare justice, and criminal justice. Our concerns for deep inequities in maternal mortality and morbidities, for the role that SUD plays in preventable maternal death, and the dangers of a healthcare system that drops women and all pregnant and parenting people after their babies are born, a child welfare system that penalizes them, and a criminal justice system marred by historic systemic racism. All of these things bring us here today. And we are so fortunate and honored to have two presenters who are able to integrate all of these perspectives and lead us in a conversation about promising policies and programs that can begin to make equity, autonomy, and life course approaches real for those affected. I'm going to introduce Drs. Turpin and Taylor in a moment. This will be followed by their presentations, each 20 minutes long, and then our Q&A period of about the same time length. We'd like you to submit your questions, as Rachel said, at any time via the chat room, but we'll wait until the end to take them, and I will moderate the Q&A, and we will end right at 1:15. So without further ado, Dr. Mishka Turpin is board certified in both obstetrics and gynecology and in addiction medicine. His primary clinical research and advocacy interests lie along the intersections of reproductive and behavioral health. He is senior physician research scientist at Friends Research Institute and adjunct faculty at the University of California, San Francisco, where he is a substance use warm line clinician for the Clinical Consultation Center. He is also the addiction medicine consultant for Virginia Medicaid and a consultant for the National Center on Substance Use and Child Welfare. Dr. Turpin has active grant funding and has published over 100 peer-reviewed articles with an emphasis on health disparities, stigma, and access to treatment. He has spoken everywhere, from local high schools to the US Congress, and has participated in expert panels at CDC, SAMHSA, the Office of National Drug Control Policy, Office of Women's Health, FDA, and NIH, primarily on issues related to gender and addiction. We'll hear from Dr. Turpin in a moment, but first, my introduction of our second presenter, Dr. Kima Joy Taylor. She is a board-certified pediatrician and public health practitioner And in 2016, Dr. Taylor founded Anco Consulting, a healthcare consulting company, and she is also Urban Institute Non-Resident Fellow. Dr. Taylor collaborates with Urban Institute researchers on a number of topics, including analysis of racial disparities in screening and treatment practices for parents with substance use disorder, management of neonatal abstinence syndrome at hospitals in California, prevention and early detection of mental and behavioral health problems among adolescents and young adults. Other areas of expertise of Dr. Taylor's include identifying policy, programming, and finance levers to improve health and racial equity, to integrate behavioral health, primary care, and social services, and to support the system change necessary to embrace cost-effective, holistic healthcare solutions. And prior to ANCA, she served as National Drug Addiction Treatment and Harm Reduction Program Director at the Open Society Foundation. She oversaw grant making to redefine and expand access to a full continuum of community rather than justice-based, culturally effective substance use services for all, and to replace the current discriminatory justice system responses to substance use. Prior to this, Taylor served as the Deputy Commissioner for the Baltimore City Health Department, as the Health and Social Policy Legislative Assistant for Senator Sarbanes, and as a practicing pediatrician in a DC federally qualified health center. Taylor is a graduate of Brown University School of Medicine, and the Georgetown University Residency Program in Pediatrics. In 2002, she was awarded a Commonwealth Foundation Fellowship in Minority Health Policy at Harvard University. How fortunate we are today to have this incredible team of presenters. And we'll begin right away now with you, Dr. Turpin.
So thank you so much for inviting me. I'm Mishka Turpin. I'm going to talk about equity, autonomy, substance use disorder, really from a Lifecourse perspective, focusing on the period of pregnancy, treatment as well, and in particular on the postpartum period. So sometimes people ask the question, why would a person who's pregnant use drugs? Doesn't she know that she's harming her pregnancy and herself and etc.? And I would say that question is somewhat ridiculous, in that most people use drugs, and some people who use drugs become pregnant. And so the question really is, what happens when people who use drugs get pregnant? And you can see from this slide, the blue columns are people who are not pregnant. This is past 30-day substance use. The next three columns are stratified by trimester and separated by substance. And you can see that compared to pregnant people, people who aren't pregnant are far more likely to report past 30-day substance use. Use decreases across the course of pregnancy, and it differs by substance, with people cutting back alcohol the most, cigarettes the least, and illicit substances somewhere in between. So when we talk about substance use in pregnancy, what we're not talking about is people who initiate substance use during pregnancy. We're talking about where the reproductive health life course, getting pregnant, staying pregnant, and delivering, intersect with an addiction life course. Use, misuse to addiction in a particular moment called pregnancy. So really, people who continue to use a substance in pregnancy, most likely they have a substance use disorder. Everyone knows that smoking cigarettes or drinking alcohol or using cocaine while pregnant is harmful. Some people can stop, other people can't. Those that can't likely have a use disorder. And here you can see the definition, the new definition of addiction from the American Society of Addiction Medicine, as well as the DSM-5 criteria for opioid use disorder. So people who have the condition of addiction, they need treatment. And when we think about treatment in pregnancy, we think about treatment for addiction, i.e. medication when it exists, plus or minus behavioral counseling, co-located with prenatal care. And this is really the gold standard, the integrated model that was really first described in the 1970s. And you can see from these data from Loretta Finnegan, published in 1978, that if we contrast people who received treatment co-located with prenatal care who used substances contrasted with people who did not receive treatment, the bulk of this was for low birth weight, whereas half of people who did not engage in care had a low birth weight infant. People who engaged in treatment had a low birth weight that was roughly similar to the rest of the population of people who did not use substances. And this really is the operant distinction, that between treated and untreated addiction. Really at the core of maternal child health care is the optimization of maternal health. Healthy mother equals healthy baby. Chronic disease management improves birth outcomes across the spectrum, across all different types of chronic conditions, including addiction. And you can see here these data, these are from Massachusetts, the most recent data to demonstrate this, that people whose addiction was treated had birth outcomes that looked much more similar to a population of people without addiction than to people with untreated disease. In other words, the most salient public health clinical distinction should be between treated and untreated addiction, trying to get more people treatment. And for opioid use disorder, the core component of treatment is medication. As demonstrated in the recent SAMHSA clinical guidance document, these are 3 of the 5 outcomes for which there was the greatest agreement amongst the expert panel. That buprenorphine and methadone are the safest medications for managing OUD. Transitioning from one to the other is not recommended, and medically supervised withdrawal is not recommended. And when we think about the benefits of medication for opioid use disorder and pregnancy, there are benefits that we stabilize the mom, which actually allows a platform for the delivery of other services such as, prenatal care, psychosocial. We reduce the likelihood of acquisition and then vertical transmission of HIV, Hep B, Hep C. But just as mom gets stabilized, so does the fetus. And really the risk of untreated opioid use disorder is not the opioid to the fetus, but the cyclic repeated cycles of withdrawal, which prematurely activate the hypothalamic pituitary axis and lead to a cascade of events, including low birth weight, preterm delivery, and etc. So despite these benefits of medication and treatment for opioid use disorder, currently in the United States, this cartoon kind of tries to represent this. You've got the population of people with opioid use disorder, of whom, between 40 and 80% receive any treatment, of whom between 20 and 80% receive any medication, of whom a even smaller proportion that we don't know receive the integrated co-located services that are considered the standard of care and have been described in the literature since the 1970s. So treatment works, but the goal of treatment is not more treatment. The goal of treatment is recovery. And recovery is more than abstinence. It's about connections to others, social relations. It's about purpose. It's about serenity. It's fully compatible with the use of medications. And we can also think of recovery as really, like in many ways, just another word for wellness or for flourishing. In other words, it's not something that's necessarily specific only to addiction and treatment. So I want to transition now and talk from the treatment and from the pregnancy box and take a step back and think more about the life course, in particular, looking at what happens after the conclusion of pregnancy. And even though medications work and work very well for the treatment of opioid use disorder, adherence to medication, in particular following delivery, is poor. As illustrated here by this graph, you can see a marked sort of decrease in adherence and to medication and engagement in care the further one moves out. And we know that when people stop taking medication, they are likely to have a recurrence. And this really raises a question for me. We know it's almost a truism that addiction is a recurring, remitting illness, and that's part of its natural history. That's how it's taught and presented, and that could be true. But I want to ask the question, is it recurring and remitting because we actually only provide episodic care? Any episodic care for any chronic condition will make that condition appear recurring and remitting. And so right now, I think what's happening in some states and some localities is we're actually providing chronic disease management for a chronic condition. And my hypothesis would be that addiction will look a lot less recurring, remitting under that treatment paradigm than how it has before. So I mentioned the postpartum period previously, and really we've started to use the term the fourth trimester to refer to this. This is the year following delivery, and it's a critical period. This is really, where the mythic idea of the ideal mother collides with the reality of caring for a newborn. This is a period of mood changes. There's a new baby to take care of in the family. This is a critical period from attachment, but it's also a neglected period from the medical care setting. Pregnant people have weekly visits at term leading up to delivery and maybe one thereafter. Care shifts from being mom-focused to baby-focused, and generally speaking, shifts from being medical to non-medical. And there is a lot more recent attention to this period of time, in particular around maternal mortality. Here on the left-hand side, this shows the likelihood of dying during childbirth from the mid-1800s until the 1990s. And you can see this is one of the success stories of 20th century medicine, whereas women around the turn of the century, 5% died during childbirth. By the time I was entering medical school, it was about 1 in 10,000. Now, on the right-hand side, you can see the increase since then, since that nadir in many ways, the likelihood of dying in childbirth has been increasing in the United States. This is in contradistinction to the rest of the developed world. And there are lots and lots of reasons for this. And at the core, we know that there are marked racial inequities in maternal deaths. In fact, Black women have 4 or 5 times the odds of dying during childbirth than white women do. And we say, sometimes disparity, which is really a euphemism for inequity, but really inequities is a euphemism for racism. And in the United States, the driver of racism is the false ideology of white supremacy. And just as these forms of discrimination have at their roots sort of punishment and ignorance, we see among women with opioid use disorder similar rates of maternal deaths. For example, people with opioid use disorder have 3 to 4 times the odds of dying during the delivery hospitalization. And in many states that are looking at the postpartum period, they're seeing that overdose and other behavioral health conditions such as suicide are the leading or one of the leading causes of maternal deaths. And these are data from Colorado. And most of these deaths happen later in the postpartum period. And we know from other data that medication is protective of overdose and overdose death. So these are data from the state of Massachusetts showing not just death, but also non-fatal overdoses. You can see the decrease through the course of pregnancy and the rate only increasing afterwards. And the bottom shows the protective effect of medication on preventing overdose and overdose death. But one aspect of the opioid crisis that has received less attention is how it has affected the child welfare system. We've seen a marked increase in the percentage of out-of-home placements, i.e. removals, i.e. foster care placements for infants because of parental alcohol or other drug use. Currently, it's at least half of all foster care placements are for parental substance use. Most of those placements happen within the first year of life, and reunification is less likely. And you can see here on there are some states where over 3% of all births go into the child welfare system. And this sort of heterogeneity, as well as rates of removal, is driven by state policy. In particular, these are data from the Guttmacher Institute. You can see the weight of state policy is towards the punitive. Those would be the first 3 lines. States that consider substance use to be child abuse, grounds for civil commitment, and in particular, the mandatory reporting. And you can see then there's less states that actually have what we would call supportive policies. Those would be the bottom 3 rows. And punitive policies are actually not only not evidence-based, but there are good data that show that punitive policies do not improve health outcomes at the population level, both in terms of substance outcomes and in terms of obstetric outcomes. And these are data from Sarah Roberts and her group's work looking at alcohol related policies, and states that had punitive policies had actually slightly increased or no change in the odds of low birth weight, preterm delivery, and etc. Interestingly, punitive state policies related to substance use have been increasing in the United States. And this is different than state policies and even federal policies related to substance use in general, which have been moving away from the punitive. You can think of criminal justice reform in general, like decriminalization of cannabis and et cetera. The general arc of policy around substance use is bending away from the punitive. But for pregnancy, it's actually becoming more punitive, as illustrated by this graph on another article of Sarah Roberts on the right. So the question is why? Why is this policy is moving in one direction at the, in terms of substance use in general, and in the other direction in terms of substance use in pregnancy? And I would say, echoing Sarah Roberts' interpretation of data here, that the reason for this has nothing to do with substance use policies in general, but everything to do with restrictive reproductive policies. We know that states that are implementing punitive policies for substance use in pregnancy are also implementing punitive policies related to reproductive health in general. So what do we do? How do we approach clinical care, public health, and public policy? And I would say that we need to make sure that what we're doing, what we're speaking to, and what we're moving towards is both evidence-based and person-centered. And by evidence-based, I mean grounded in science, both the policy science, clinical science, and et cetera. And the science should focus on the life course. And we need to be aware of the fact that, generally speaking, we have exaggerated what the harms of illicit substances are, and we've actually minimized what the effects of licit substances are. And in general, in this topical area, we overstate the importance of the intrauterine exposure, and we neglect the role of the caregiving environment. And for person-centered care, this is ethical, this is grounded in human rights, this is beginning from the idea that reproductive health is a human right, which is the right to determine whether and when to become pregnant. Person-centered care is grounded in autonomy, supporting maternal subjectivity in decision-making surrounding pregnancy. And specifically, I think we need to remain attuned to the unique demands that we place on pregnant and parenting people, in particular on their bodies. And with that, thank you very much. Here's my contact information, and we're going to hear from Dr. Taylor next.
Hello, I really want to thank you all again for inviting me to speak. These topics on equity, autonomy, substance use, women and infant health are really dear to my heart. And I'm going to repeat many of the things said by Mishka, but I think reinforcement can be helpful. So I actually want to start a bit at the 10,000 feet high look and then drill back down to the postpartum period. Let's see, can I move it? Yes. So women are people. That seems pretty basic, but this autonomy piece is important. Women are often not thought of in any real depth until they become pregnant, but we women are whole people, not simply vehicles to carry children. And as such, there should be a whole range of accessible, culturally and linguistically effective physical and behavioral health services available for women before they enter their childbearing age and before they're pregnant. They would have relationships with providers and systems that are there for them when they need help. If these were available, then they're healthier overall when they do become pregnant, which can improve pregnancy, and overall health outcomes. This is true whether the woman is using substances or not. She should be treated to services that are designed to improve her overall health, as well as, should she be pregnant, the infant's health. This, alas, this is often not the reality. And as this slide shows from Kaiser Family Foundation, many women do not have a regular source of care, not to mention the disparities that you will note. Wrapped up into that lack of access to care are disparities that exist even when women do have access to services. Even if we only focus on pregnant women, when they contact their OBGYN, we find there are myriad disparities across race and ethnicity, and they're not shown on this slide along sexual orientation, age, disability, and other intersections. Even if we decide to only care about pregnant women, society, health, and social systems do a poor job ensuring favorable health outcomes for all. So, before we even get to talk about women and substances post-pregnancy, we're in pretty shaky ground. This is important not to shame all of us, but to help our thinking moving forward. The reality is that as we seek to think about change, improve the way we serve diverse pregnant women who use substances, we must think about creating remedies that help change and eliminate these baseline inequities and inefficiencies. Adding a great program to an infirm base simply makes the whole structure fall. But when one adds in substance use, it becomes a much more complex because of society's historical beliefs about and response to people who use drugs. As Mishka mentioned before, and which needs to be repeated, substance use is a chronic condition which can be and should be treated and whose sequelae can be ameliorated with health and social service responses. However, we, society, and all of our infrastructures must truly believe addiction is a chronic condition that should have health and social service responses. We've paid it a lot of lip service, but our structures do not reflect this belief. We are working against a long history of using substance use as a way to punish, discriminate, and imprison people who use drugs, and especially those of color. To improve outcomes and care, we must reckon with and be honest with the past because it requires changing these structures. Race has been a factor in criminalization of drug use responses since the late 1800s when San Francisco targeted Chinese residents. And this has continued from that time with other races. Though some say this is less about vilifying other races and more about protecting whites, I actually think that framing is pretty racist too. But the deadliest for people of color was the war on drugs. Today, many people say, we don't just care about the opioid epidemic because it started in white communities. It's really that society just learned or realized that it's a health issue. Nope, that is false. The AMA recognized alcoholism as a disease in the 50s. Nixon knew it was a health issue and increased access to methadone, especially in response to numbers of vets returning from Vietnam needing help. However, at the same time, his administration proactively used the drug war as a tool to destroy communities of color, as shown with this quote by his domestic policy advisor, Ehrlichman. The resultant justice disparities have had overwhelming negative effects and impacts on communities, but that's a different talk. If you own that history, you can think of new ways to change it. If you do not learn from the past and thus repeat it. You will also use odd frames. The justice response was never supposed to be a remedy for a health condition. Thus, comparing success to something that was not supposed to be a treatment is unfair at best, dangerous, and mean at worst. The health system was complicit in the war on drugs and did not take ownership of, identify, or offer evidence-informed services for substance use, and many parts of the health system still don't today. This is in part to the fact that health and social system actors lived in the same world as everyone else, received the same morality and race-based information, and embraced the same morality and race-based frames, which didn't include health responses. Advocates began to loudly call for health responses, many of them criminal justice advocates, not health advocates. And as such, we began to move in a better direction with the passage of the Mental Health Parity and Addiction Equity Act of 2008 and the 2010 passage of the ACA, which shifted the baseline by requiring not only access to substance use service, but access theoretically and parity to physical health services. which we did admit we're already on shaky ground, but this is still an improvement. It's within this new, still not accessible health and public health frame that we should address how and what kind of services to provide pregnant and parenting mothers who use substances. What should happen when a pregnant woman uses drugs? They should have easy access to high quality, culturally effective, evidence-informed substance use services, including harm reduction, treatment, including medications if available. And by if available, I mean if there are medications available for that particular drug, like cocaine there isn't, but not if they're available in the territory. Recovery and other social services and supports as needed, and use the results as a means to improve mothers, infants, and families' outcomes. They should have easy access to high quality, culturally effective, evidence-informed OB and other physical mental health services as needed. There should be screening for and referral to culturally effective social services and supports as needed. Case managers to help navigate this needlessly complicated system, and continued outreach even if the mom doesn't make it to every single appointment. At the end, we should also assess whether care services and outcomes are consistent across different populations, or do you need to work with patients more to make the practice more effective or even refer. Finally, as in all of medicine, we need to listen to the mom and what her needs and concerns are. But does this happen? No. In fact, pregnant and parenting women who use drugs have difficulty accessing trauma-informed, culturally effective, patient-centered care, in large part because of the legacy of our punitive responses, and in a smaller part because of a desire to care for the infant without an understanding of what health practices are actually more effective to care for the infant, like medications for OUD. As we look at what's actually happened, it is not in the interest of the mother's health, the infant's health, the health of the dyad, and the family. First, there's a laser-like focus on only opioids. Substance use is more than just opioids. Myriad substances, including cigarettes and alcohol, can have negative health implications. We do not ask about or offer support on a regular basis. But even if one solely focuses on opioids, the system doesn't even require the provision of evidence-informed care, which includes medications, as Mishka mentioned. In fact, some systems and providers actively discourage such evidence-informed care. Laser opioid focus has other sequelae. By only focusing on, pretending it is only about prescription drugs, you're creating barriers and discriminating against those who did not start with prescription drugs. By only focusing on opioids, you're discriminating against those that use other drugs. Many of them also use opioids, but are also denying resources and care to people who use other drugs. How do we start? This is really hard. The legacy of criminalization reaches deep, and we need more work. I want to give an example just to show how complicated it really is. Let's look at non-consensual universal screening, which incidentally may mean verbal screening, urine screening, meconium screening. We don't even have really a definition for screening. But if you ignore the racist and criminalized past, universal screening is an obvious, great public health idea. However, let's look a little more closely. First, rarely is there truly universal screening. There's screening of who we think may have issues, and that's defined by our or the system's biases. And as Mishka mentioned, the consequences can be dire. In many states, pregnancy is criminalized. And we say it's in an effort to protect the child, but then we often don't give medications and the other behavioral health services that actually improve the child and incidentally the mom's outcomes. There are also racial and ethnic disparities, as Mishka mentioned, in terms of who's referred to child welfare and CPS, who can access and or afford the evidence-informed services and supports needed for family unification. Is removing the child always best? I am not supporting leaving infants in dangerous situations, to be clear, but is removing the child always best? Because if this were so, there would not be so many racial and ethnic disparities around these outcomes. Some people said, well, if we were going to alleviate disparities, would that mean putting more white kids into child welfare? Well, if it's good for one, is it not good for the other? Or do we really need to rethink the system for everyone? Pretty much every mom wants to be with her infant, including moms with substance use disorder. And a not surprising development, criminalization and risk of losing one's child makes many moms eschew prenatal care, which can improve outcomes, not just around substances, but all health outcomes for babies and mothers as they get access to prenatal vitamins and they have their glucose checked, etc. Alternatively, if mothers interact with structures that are focused on improving health, social outcomes, and family preservation, they're offered access to evidence-informed, culturally effective services along the substance use service continuum that are geared to help mom keep or rapidly get back her infant and improve her overall well-being. Okay, so finally, postpartum. Mom had the baby. What happens next? Honestly, in any given situation, if we're honest, who knows? Who knows how the mother is doing? Does she have depression? Is she accessing substance use services? Is she on target to get her 6-week postpartum visit with everything that's going on? Who in the system knows, much less warmly follows up? Is it CPS? Is it pediatrics? Is it OB? Does she have access to a case manager that's going throughout all of it? What system is actually following this mom? Who cares? Who in the health system is responsible for mom's health? Is it the OB, the primary care provider, the child's pediatrician, a case manager that serves both mom and child? Who is supposed to care? I would say ideally all of us working together. And it creates a system, and can the system do that and still ensure respect and privacy? Who should have incentive to care? The OB, the pediatrician, payers, employers, education systems, the entire community has an incentive to see positive outcomes. How can we get them to care? And this is where I think a lot of the work is going to focus. Is it team-based care so that people who are overworked and exhausted have support in order to provide the best, most culturally effective care? Is it outcomes-based pay that incentivizes outcomes and offers providers to provide time and resources to do a better job? Is it bundle payments? The answer to all these questions right now is it depends, and it often doesn't depend on what's clinically effective. These are major gap alerts that we need to fill in. We need to fill in all of these boxes with concrete, reliable answers that do not differ by who the mom is or whether she uses drugs or what type. What could the new world look like? Recognizing there are options needed because no one size fits all. What people need to thrive is not actually rocket science. It is the things we all need. It's the things we listed before: access to full continuum of high quality, culturally effective, and linguistically effective, clinically effective, and evidence-informed substance use, mental health, physical, and social services for mom, baby, and family as needed and as clinically appropriate. Systems must be in place to address myriad concerns regardless of ability to pay, and data, including subgroup data, must be collected to ensure services are positively affecting all individuals regardless of race, ethnicity, primary language, sexual orientation, and more. And a system must be ready to admit when the data shows there are disparities and work to develop solutions to achieve health equity. This can occur through linked care. It can occur by having care management across pregnancy and postpartum, though ideally, again, inclusive of before pregnancy. It is going to require humility, the time and ability to listen, and the flexibility to change and fit patients' needs. We need payments and systems that allow for this. We need supportive SUD services for all types of substances: non-punitive, community-based prevention, harm reduction, or secondary prevention, if you prefer to call it that, treatment, including medications, recovery services that are evidence-informed, not based on morality and justice responses. We need physical and mental health services that are accessible, affordable, and effective. And I would say social supports and connections. This is going to require rethinking what is available and changing to what should be available to improve health and social outcomes. Is there hope? Absolutely. And I think this is a somewhat new field, and this is not a time to say, oh, well, we're only going to follow every single wheel that's been invented before, because that earlier framing of justice and criminalization means that some of those wheels were pretty square and were not meant to improve health outcomes, as I said before. So it is going to be a new journey of innovating and understanding and getting data and figuring out better what helps. So we need to take ideas from other areas. Many other areas are looking at the postpartum period with mom and infant, trying to improve maternal depression outcomes, looking at the early social and emotional development and how that you empower mom and make a healthier mom to help her empower and have a healthier baby. There's work going on in these areas that really can be transferred to work with postpartum moms with substance use. Excuse me, I have a frog in my throat. We can embrace culturally effective, patient-centered, high-quality, evidence-informed policies, programming, and practices. This is going to require deep humility, which I'm a doc. Docs don't have a lot of that, and we need to start embracing it. And it's also going to require implicit bias work. And note how I didn't say training, because it's going to be ongoing work for everyone. We can seek to increase access to services and to eliminate disparities at the same time, which is going to require data and subgroup data. You're going to have to know your service area, who the people are, what drugs they're using, what services are available, what services need to be created. And ask the people who come to and use your clinic services, do you go to that particular place? Is it culturally effective? Is it a place you would return to or recommend to others? it is going to require some training. This is a must. We're not taught about substance use in any reliable way in most of our health training schools, including medical school. You wouldn't try to treat type 2 diabetes without any education, so don't do it with substance use. There needs to be training on the most basic. What is substance use? Not just what is opioid use, but what is substance use? What does care look like? How is it individualized? Is it one size fits all? No, not every single person requires residential. And that's a piece that we need to focus on. What am I screening for? Have I talked to the patient about this, about all types of drugs? Have I gotten consent for this screening? What does happen after pregnancy? Doing some training and education about that. Buprenorphine training, support it for new providers for prescribing buprenorphine. But also I would say providers need to learn about other medications and medications for other drugs, including alcohol. And don't forget methadone. It's an oldie but goodie with lots of stigma attached. Though I would say it's likely we all need to advocate for rethinking of methadone's practice parameters. What are the behavioral health and social support referral systems available in your community? Are they culturally effective? Are they evidence-informed? Get to know them. Are you qualified to do it all? At what point do you think you need to pass on to a specialized treatment provider? And is that provider high quality? If you don't want to treat someone, should you torture them? And this is a place where I often deviate from other people, but I think if you're going to get to a place where your care is only going to be hostile and stigmatizing, then probably it is time to pass that on to another patient, another provider, whether that's because of race, substance use, or other services. This needs to be a healthy experience for the client. Diversify and expand the care team, including but not limited to case management. And yes, this includes including behavioral health specialists in your team. I feel these are key if you're going to focus on substance use and mental health services. I also think there's value in adding a peer, and many people are using peers these days to their team. But I would say when you're including people with lived experience, that does not, an experience from the neighborhood, that does not just mean the peer. You should have folks with lived experience throughout the entire care team. If we're really looking to break down barriers, you can have nurses that have a history of substance use disorder, providers, the phlebotomist, etc. And really this care team needs to have mutual respect, not only for each other, but for the clients they see. Reject the punitive frame at all turns. The health system is not and should not be the punisher. We're supposed to be the supporter, and there's other people out there, right? When you're looking at new policies, think how you can support the family. There are no perfect parents or parenting solutions. We're all winging it. But what we can do is try and do a better job, take lessons learned from other places, and study to see what is working. So those are kind of more promising ideals and principles. In terms of ideas and policies that are going on now, there should be encouraged insurance coverage over the entire lifespan, Medicaid included. Until that happens, there is a lot of movement saying that Medicaid should provide it for the first year postpartum with easy access to care. I was at one great forum where someone did say, if the person didn't link someone up to services while they were pregnant, what makes you think they're going to do it postpartum? But this is where I think that's true, but this is where ideas and trainings, et cetera, can help to improve those outcomes. Payment reform, I think, is an opportunity. Excuse me. Payers should incentivize high-quality, equitable outcomes and care that address social needs and address these health needs. There is a workforce shortage. This is something we absolutely need to address and figure out how to expand the workforce. And sometimes paying for incentivizing services can help to promote the growth of industries, but also we need to be very thoughtful about how to diversify and expand access to behavioral health providers. Make sure there are services in the community. And if not, what is the role of telehealth and how can you think about it and how is it reimbursed? There's a lot more movement also towards people doing 2-generation family policies. And this is, I mean, if providers think about being able to give time, funding, and research to innovate, this is one of the places where, again, I think we can steal from other places. One example is group visits. And there's many people know about centering pregnancy, but there's also centering parenting and other group visit structures where parents come together and get their care together with a pediatrician, but they also have access to behavioral health services, social service supports, and others from one another, but also from the system writ large. And to finish up, I am not naive. I know there are challenges to this new vision. I already mentioned the challenges on opioid-only focus. I think there's challenges in terms of law enforcement and justice approach. It's really still embedded in all arenas, and there are vast consequences from interactions with the justice system that have little to do about substance use, but are made worse by substance use. Funding. It's not just reimbursement, but it's upfront funding to really change the infrastructures and practices and to rethink business as usual and create workflows and structures that support either team-based care or other ways of providing substance use services in a holistic, integrated way. Research. The punitive frame slowed much needed research into honest effects of illicit drugs, as Mishka mentioned before, but it also slowed research on new treatments, harm reduction, and recovery measures. In terms of treatments, it's interesting that there aren't more medications for other drugs. And being able to better identify what's effective in different populations or not. Data. Random data sharing is not the answer. I am a true believer in privacy, and I don't think all the health data needs to be shared with law enforcement. But I do think the health system needs to know its own data, know what drugs people are using, know how people are interacting and engaging in the system and whether they are and whether they can be more effective or not. And again, as I mentioned many times before, there needs to be a subgrouping of the data. Mishka and I both kind of touched on stigma. Stigma is massive. You all know stigma is massive. It's society's response to people who use drugs. The reason I kind of put it towards the end is as a Black woman, I know it takes a lot of time for people to change their attitudes about people. And so while they're changing their attitudes and stigma, we need to create a system that's providing the highest quality of culturally effective care, regardless of people's baggage that they have. But it is something that we need to address. Same with racism. Policies, systems, practices, and people still embrace these past racist infrastructures and beliefs. And at times, the system doesn't want to admit or realize this, but by not identifying and owning up to the racism and stigma inherent, the programming we create are going to be less effective. And lastly, there's politics. The U.S. likes to punish, and it's not just in the substance use space. Punishment wins more votes than compassion. And so there really is this policy frame back and forth. And I'd say one example is harm reduction practices, like syringe services and other harm reduction pieces that are not naloxone, be it safe injection facilities, where politics kind of trump evidence and science that we know. And this is a place that we have to be honest that they exist and figure out ways to get over those barriers so we can provide our patients the best care that they deserve and need. And so I'm done. And again, I just want to thank everyone for joining us.
Great.
Huge thanks to both of you, Dr. Turpin and Dr. Taylor, and to all of our listeners who very patiently waited for us to clear out the tech difficulties and for feeding us some great comments and questions along the way. So again, my name is Lois McCloskey, and I'm going to begin the question and answer period now with one question that I have, and then we have several excellent ones coming in, both high level and more specific from the audience. So as someone who has been deeply invested in the last few years in what I call bridging the chasm between the health of women and pregnant people after the baby is born and their ongoing life course care in the context of chronic illness, I really thank you for shaping this and framing it in terms of that larger chasm that exists. So, Dr. Taylor, I think I want to point this to you first. You talked beautifully about team-based care, the need for mutual respect among various team players and training. I assume you also mean cross-training, which often doesn't exist. So could you, given how many chronic illnesses are of concern, substance use being a really important one that we're focused on today, can you imagine, and what would it look like, a system of sort of this team-based care during the pregnancy period that goes on through postpartum and also connects to primary care? That's a huge challenge. And I wonder if you've seen that enacted with recovery coaches as part of the team, or perhaps doulas in the case of substance use. Dr. Taylor, you may be on mute.
Oh, that's embarrassing. I was just talking away. I apologize. So, yes, and I think that is a space that absolutely needs to grow. But I have seen it occur in a couple of different places. One is in F2HCs. There's this great F2HC in New Jersey called Henry J. Austin that is thought very intentionally around that team-based care, inclusive of the pass off to the OB and the passing back to the primary care. And that, as you kind of alluded to, is very effectively aided by a care manager, be it a peer, be it a doula, be it these other infrastructures. And often that person is also a safer link to provide kind of an entree to the healthcare system. So I think it happens, it needs to grow. And this is also, for medication-assisted therapy that maybe started before the person was pregnant and or started when the person was pregnant and when they were handed off. In some ways, I think medications makes it really concrete, so easier to put together. But I will also say in some of the group places that we've had, that's been in group centering parenting places I visit or other group sites. It is often a care manager or case manager that is able to link not only the mom's team, but then link that to the pediatrician more in terms of social and other supports that are needed, like things from daycare and other pieces. And so that's happening. Now, the rub of the road is really that payment reform. In order to do the team-based care and do it well, you really do need to pay for all of those services. And so that's why I think that bundled payments and some of the value-based payment movement down the pike is something we need to jump on, think creatively about, but also in a cautionary tale, think in a way that's going to make sure we're being reimbursed for services so we're not shortchanged and then aren't able to provide the services.
Yes, thank you. So you're referring to bundled payment to bridge between postpartum care or in the postpartum period as well as beyond, or perhaps
absolutely
at least to the handoff.
Yeah, and I guess and really around that postpartum care and beyond, and inclusive of the OB, right? Because a lot of moms have continuing relationships with the OBGYNs because they may have their second or third child, or maybe it's their fourth. But yes, but really focusing on the mom's health. And I think there's been more talk around that bundle around the baby, but we need to do more around the mom.
Thank you. So next we have several questions that have come in that get to the heart of kind of balancing the big question of balancing the interests of the child and the mother's long-term recovery. So here's one along those lines. Would you please unpack the statement that we ought not, quote, overstate the importance of the intrauterine exposure versus negative caregiving environment? Is this influence, the questioner asked, a 50-50? How to balance both? That's a big question. And either of you could take it on. I might start with you, Mishka, Dr. Turpin.
Okay. Yeah, thank you for that question. There's danger in false dichotomies, and this area is replete with them. It's not uncommon, to see a headline that says something to the effect of, case pits rights of fetus versus mother. And the answer is both. And I think we have a hard time sometimes. We have to sort of resist that oppositional way of thinking and really struggle to articulate and then put into practice what we really mean by the dyad. So what we know from there is 50 plus years of literature on outcomes of children who were in utero exposed to substances. I'm excluding tobacco and alcohol, where the data go back longer than that. And we see there are subtle effects for some of the illicit substances, but the magnitude of the effect, really pales in comparison to the importance of the caregiving environment.
There's, I think, critical work that was done by Hallam Hurt, who's now emeritus faculty in pediatrics in the late 90s and even into the early 2000s, and she looked at sort of the operationalizing the caregiving environment. And her research emerged from cocaine exposure. And her hypothesis was that individuals who were in utero exposed to cocaine would have decreased IQ at 2 years of age, in contrast to children who were not in utero cocaine exposed. But what she found was that there was no, to at best tiny minimal, but really no effect of cocaine on IQ. But within these children, there was a whole range of IQ, from below normal, normal to above normal. And this sort of led her on a career change course from in utero substance exposure to what is the caregiving environment. And she did home visits and in a lot of her research sort of operationalized what are the parts of the care environment which are associated with, elevated IQ. And it's things like learning stimulation, language, other sort of emotional support. And the one thing that is not associated was the actual physical environment, which is, I will note, the one thing that child welfare in its home visits looks at the most. So the other way to think about this is looking at sort of risk, how we think about prevention, maybe for substance use disorder, and how important, safe and stable and loving home environments are to not have adverse childhood experiences, which are associated with a whole myriad of health things. So if I had my druthers, we should be putting more programming and attention into, providing, as Kima mentioned, providing comprehensive dyad family and community support in those critical early years, and paying, less causal and false causal attention to what the sort of consequences of substance, the chemical exposure of substance use might be.
Thank you. Would you like to add anything, Dr. Taylor, or shall we go on?
Let's go on.
Okay, so not surprisingly, we have a set of questions that really go to Child Protective Services and many of the problems that you raised. So here's one, excuse me. There's two I want to say. Why aren't we seeing more physician advocacy against the expansion of reporting and mandatory testing? Now, you're both physicians, so let me start with you, Dr. Taylor.
I think, wow, that was a real echo. Humbly, I think it's hard to get physicians to advocate writ large. And I think that's often because they're just overwhelmed and exhausted by seeing so many patients, and then to do advocacy in general. And so while it is frustrating that's not in this space, I would not say it's just in this space. And so I think in order to change that, I'm really thinking about, educating the docs on what's happening, educating them on what that system actually is doing and what it looks like, but then also looking at it from their perspective and making it time easier for them to be able to. But it's not, I would say it's unfortunately not just in this discipline.
Yeah. And it seems to go at the heart of everything you just said, Mishka. There's a lot of kind of reorientation, rejiggering of physicians as well as everyone's orientation toward non-dichotomous thinking. But would you like to add anything?
Well, I certainly would want to echo that I think in general, like advocacy and the sort of public, social, and professional role of physicians don't always align, with the exception of, a professional society, whatever it is. And I mean, I guess ideally, I would like to like reconceptualize what we think it means to be a physician. And, you know, and think about what is our, you know, responsibility to the individual, which I think does mean, you know, advocating outside of strictly, you know, determined clinical spaces, i.e. with child welfare, family drug courts and stuff like that. But also there's a, you know, there's a public role. I mean, our status historically might have declined, and I think to some extent for very good reason. But you know, there are some examples. For instance, in North Carolina, the pregnancy substance use criminalization law that sunsetted. Part of the reason it sunsetted was because of, and not just physicians, but providers in general and other community-based organizations that, you know, went to the state General Assembly and advocated successfully for the sunsetting of that clause. But I think at the core, you know, there's a long list of things that, or domains that you know, physicians aren't well versed in. And that would include, you know, child welfare. And I think, you know, so therefore, some of this is just emerges from ignorance. And there is, I think, a false assumption, you know, that is better safe than sorry. It's better to make the report to child welfare, you know, because I don't really know, you know, I can't really make this assessment myself. So the safer thing to do is make the report, rather than an awareness of what the potential, you know, negative consequences of that report might be. And just to tie this question into the one before, when we think about the importance of the caregiving environment, you know, we're talking about, you know, thousands of children a year in the United States that are being removed because their parents have a chronic condition of addiction that oftentimes is treated at the time of removal, and what are the, you know, developmental consequences of these unnecessary removals on these children and on their life courses. We are, you know, it's likely that we are actually causing a lot more harm than we are preventing.
And that actually goes right to a question that just came in, that is, how can we ensure then a positive caregiving environment without getting CPS involved? Any ideas on that? And I'll start with you, Dr. Taylor, in case you want to add as a way of adding to what Dr. Turpin just said, and then pass it back.
Sure. And again, this speaks to a life course of a woman, but when she's pregnant, there are states that are thinking about how do you create a care plan? How do you show that you have services in place for mom? There have been many, so this is not the first epidemic, crises, much less the first opioid epidemic. There have been substance use epidemics in the past. As a result, people have put together family recovery plans that help children, when it's appropriate, stay with parents, providing the parents the support systems that they need. Family recovery plan is just one of them from Baltimore. And it provides the support that kids and families need so that they can stay, and so that both moms, infants, and the dyad and the family will be healthier. That can include basic things like food or housing, as well as substance use services, as well as mental health services or daycare. But it really is about what do we think of as whole women. And that's outside of that. Is plan was to keep people out of the child welfare system. So that's in conjunction, but you can understand having the same system ahead of time. And this part, again, is taking from past experiences and past the meth epidemic and the aughts, what has worked before. So there is literature on family preservation, but that needs to be given to providers, OB/GYNs. They have to start to link with and understand what social support systems there are in place. And that really gets to what I was talking about, that funding for upfront changing the way we think and work, and the training necessary for that to happen. And you know, there are, I would say, even in that team-based care, maybe providing payment for those doctors to then be able to advocate for what should be changed and what could be better. But that's probably Don Quixote world.
Great idea. Anything else on that question, Dr. Turpin? If not, I'll move on.
Well, sort of two levels. One is there's, and I didn't mention this in my talk, but there are clear, like, marked, racial and class inequities, not just in who gets reported, but what happens to the report to child welfare, to foster care placement, and loss of custody. There's one place that I've heard of in the United States, which that CPS is doing masked assessments on custody hearings. So they're taking the assessment cases that they're seeing, and somebody is, like, blackening out, all, like, sort of identifiers of race and class. And when they have looked at this, they've reduced, the racial inequity in custody loss. Which is, so that's a small step. But I think the big question is, why are certain conditions sort of caught up in child welfare and others aren't? And how can we uncouple sort of the punitive surveillance and and punishment that's contained within child welfare, and augment the access to social services and other needs that relate to social determinants, and things that can actually help to maximize and support the importance of, like, the caregiving environment in those early years. And I don't know how you do this if child welfare reports are tied to urine drug test results, or any of that state level policy that I touched upon. And the only way kind of around that, and this is an idea that's been floated in the social work literature for decades, is to universalize a social work assessment at the time of delivery. It's not just people who use drugs or people with addiction that need services after delivery. Lots and lots of people who deliver do. And so if we could universalize access, and Kim has mentioned ways to sort of pay for that theoretically, that would be the only way to undo the stigma and discrimination that is bound up with addiction within our current system.
Thank you so much. We have remaining 2 minutes, and you gave us a great segue into a set of questions that have to do with payment. I'm going to say one quickly and then just take your quick answers. Is there a reimbursement mechanism by which we can have appointments with each other to catalyze multidisciplinary care, number one? And two, related, how can we include behavioral and social support in the healthcare system? And others have said sort of the same thing. How can we really get to a place where we can reimburse the behavioral health integration? Those are two big ones. You each have 1 minute to give us your thoughts. I'll start with Dr. Taylor.
Yeah, I think that we're not there yet. I think the best way to do it is thinking through bundled team-based care, but it can't just be for opioids. You have to collect that subgroup data to make sure you're right just for every person. And you have to make an argument that the social supports are needed and why. And there's no one social, a lot of insurance companies are now covering social determinants, but they're like, we're only covering transportation. Well, it needs to be, client influence what the social determinants are and have some flexibility. And that's going to require that advocacy, and docs need to be at the table.
Great, thank you. Dr. Turpin?
This is a great question, and there's stuff around integration within some of the ACA language that sort of pointed towards this at a 10,000-foot view, but we really grapple with it on the ground. The example I have that isn't as comprehensive as it could be, but moves towards there. In Virginia, Medicaid, this is again like within office-based opioid treatment. So there's a mechanism through a fee-for-service model to bill for quote-unquote care coordination. And I think that was a big step, but in this direction. So there are actually existing, within a fee-for-service system models of doing this that could be enacted elsewhere.
Can I say something really quickly, though? I'm sorry.
Sure.
Because I totally agree with that. And I just would caution providers that when they're doing that, making sure they're being reimbursed effectively. Because sometimes, and I'm an F2HC providers who are like, I'll do everything for free. And then you can't keep the roof over your head. So this is also the time to be really thoughtful about the cost of those services and what they are when you're negotiating with those payers.
Thank you.
Very true.
Yes. So that is an excellent place for us to end. I wish we didn't have to, because this could go on for hours, and I'm sure everyone would agree that you've covered so much ground thoughtfully. And for our listeners, the great news is that Drs. Turpin and Taylor have agreed that if we find a few questions that cluster together and can best be answered by email, or by a slide or two, we will post those answers along with the slides that we're going to post. More on that in a moment. And then for other questions that come to you or that you've submitted that we didn't have time to answer, we've provided their email addresses, and they very generously have agreed to take emails from individuals with your burning questions. So I want to thank both of them so very, very much for their presentations, conversation, the ideas you've stimulated, and the generosity of offering to keep it going. So thank you, thank you. I want to end by, we'll post slides on both the BU Center of Excellence website and the Harvard Center of Excellence website. And with acknowledgement of our funding from the MCH Bureau, we will send out, Rachel will send out an email to everyone who signed up for this webinar, giving them the links to those sites. And with that, we will bid you adieu and wish you well for the day. Thank you all.
Thank you.